Hello, everybody, and welcome. Dr. Alberto Panero here. I have the honor and privilege to be chatting today with Peter Everts, who's been a mentor to me and also a colleague. A little bit of background in terms of when we talk about PRP and platelet dose. He's the one who introduced me to the high dose concept, originally with the Bansal paper. So hence why today we're going to focus on, just talking about the 10 billion topic. Peter was actually one of the first to publish and talk about a dose response curve to platelets. So we're going to try to get into that a little bit. So Peter, obviously you've been a pioneer in the platelet science and orthobiologics. Can you walk us through a little bit how the understanding of platelet dose has evolved over the years?
Yeah, well, thanks for being here, Alberto. Thank you so much.
Yep.
Yeah, it's an interesting question. So we need to go back quite some time in history, right? I mean, I got started in this field of medicine in 1989, and we had large, bunky machines to produce PRP. The good thing we did in those days is we took samples from everything we did.
Yeah.
So the numbers we achieved were in the area of where we are, where we think now is going to be the dose, 10 billion. But it was mainly generated because we had a higher volume of blood to work with.
Got it.
I mean, the devices were maybe not that specific in creating high dose of PRP.
Okay.
Then what happened is we made these devices smaller. We got to do tabletops.
Yeah.
And all of a sudden the volume dropped as well.
Gotcha.
So we get to 30, 60, 10 cc kits, 60 cc kits.
Sure.
So the dose, the total available platelets drop like hell.
Boom.
Boom.
Yeah.
And then, interestingly, when we started to look on patient outcomes, we had more papers. I tracked down about 90 to 100 papers.
Yeah.
Reviewing no beneficial effects from PRP.
Sure.
Whether it was in joints, whether it was in tendons. And from there we say, well, what is it? Why did some studies work? Why did some studies not work at all?
Sure.
And then when we did the analysis, it was pretty clear the number of platelets, that's what we thought at those times,
Sure.
they make a difference.
Yeah.
And then when we come up to our conclusions, looking at both the tendons and joints and spine, Bansal published his paper on knee OA, looking at 10 billion platelets being the magic number that patients were free for symptoms of knee OA for more than a year. So we came from high, we went down, understand why was not getting the results back, and then we got hinted by Bansal initially that we need to be in that space.
Sure.
10 billion.
10 billion. Now, when I started doing PRP probably 13, 14 years ago now, and it was more about a low dose, and I've always been kind of low dose, multiple injections.
Correct.
And my practice has evolved, to stay with the literature. Do you see a role at all for multiple low doses or multiple medium doses? Or are you just, hey, we know it's 10 billion, hit it once and be done with it?
Well, I don't want to be rude, but think about the oath of Hippocrates, right?
Yeah.
First, do no harm.
Sure.
So I mean, if you're going to inject in a knee joint, you can do it once instead of 3 times or 4 times.
Sure.
That will decrease the risk of potential complications.
Right.
So I understand there are not many devices that can deliver from a 60 cc kit 10 billion platelets.
That's correct.
Why don't you take a little bit more blood?
Right.
You have the needle in there, the patient is not going to suffer. And again, back in the old days, we took at least 180, always. On average, we did 240.
Gotcha.
And the patients were fine.
Right, they did fine.
There's no issue. So, long story short is, I believe if you can do it in one session, you should be good to go.
Got it.
Because each injection causes inflammation by itself.
Right, and it carries its own risk.
And on top of that, it carries its own risk. So before you get to the point of complete resolving all the, let's say, the consequences of sticking a needle in a patient, which always gives you acute inflammation, not chronic, right? That, get away from it, do it once.
And be done. That's very understandable.
Yeah, and get a booster done eventually if you need sometime later, but that's my personal take.
Understood. Now, in terms of, just to make clear for the audience, we're talking about platelet dose, which is total deliverable platelets not to be confused with platelet concentration, right? Because a lot of times
Correct.
when I started, we used to talk about, 2x, 5x, 10x. And I think it's important to understand we're talking about platelet dose, which is how many total platelets you've delivered. And going to your point, even if you have a device that can do 10x, if you think about with ACDA, you may be drawing 50 cc's of blood. Even at 10x, your baseline platelet concentration needs to be about 200,000 platelets per microliter if you're going to be injecting 5 cc's into the joint, right?
Correct.
So understand that you should try to reverse engineer where, okay, how many platelets do I want to deliver? What's my patient's baseline platelet concentration? Do I know what my device can do? And then from there, most of the time I would say you're gonna have to draw 90 or 120 cc's of blood.
Yeah, correct. And let's be even more specific on the dose.
Sure.
Actually, it starts with total available platelets. So you take a unit of blood,
Yeah.
60, 120 ml, you make your PRP, that's what you have available. So if you're going to do multiple injections in a knee, like a meniscus or intra-articular or anything else,
Sure.
then you're going to have the dose regimen in there.
Got it.
So let's say you have, 10 cc's of PRP,
Yeah.
you have 20 billion platelets.
Sure.
Now you're going to do 5 in a joint, that's 10 billion in a joint, and you have 10 billion left to do something else.
Do something else, yeah.
So it's total available platelets, and the available platelets you're going to split
Sure.
in what you're going to inject as a total deliverable dose.
Understand. So your concept is, hey, get yourself 20 billion platelets, and therefore now you can disperse them.
No, you need to have a treatment plan of attack
ahead
first.
of time, no matter what. Okay, got
Right?
it. Don't just get to 20.
No, don't get to 20 out of nothing.
Yeah.
You say, listen, this patient has knee OA, and you know what, he has a meniscus tear, so I
Sure.
want to treat both.
Got it.
And then you make your algorithm,
How
what
you're
it is, how much you want to inject in the meniscus,
Sure.
and then, but don't go the route that if you're short of PRP, you dilute it. Because
it.
that's what I see quite a lot of things
Sure.
happen.
Sure.
So, but anyway, yeah.
Now, what are your thoughts, and even like Dr. Patel published a superdose study a few years after Bansal, both used 8 milliliters of fluid, right, or of plasma to deliver in Bansal's case, 10 billion, in Patel, I think it was 5 billion. What are your thoughts? Does the volume make a difference, or is it really just about the dose?
No, the volume makes a difference. And what you need to understand is how platelets work,
Okay.
right? So platelets function better
Yeah.
in a lower volume.
Sure.
So if you have, let's say, 10 billion platelets in 10 cc's, they
Yeah.
don't feel as comfortable as 10 billion in 5 cc's.
Got it.
So looking at high volume injections versus low volume injections, what really makes a difference is keep the concentration small.
Yeah.
The platelets behave way more effective in the smaller volume than in the bigger volume.
Got it. And in terms of if there is an effusion, obviously that's going to be synovial fluid that will dilute your prep. Do you suggest to remove it? Okay.
Yeah.
I would agree with that. Here's, kind of some of the things that, we've had discussions with, also with Luga, is the leukocyte content, right?
Yes.
And, obviously the trade-off with a lot of the systems is that if you're going to get 10 billion platelets, you're probably going to be capturing a lot of white blood cells as well.
Correct.
Is that accurate? So, when we looked at some of the earlier data, it was all about, leukocyte poor injections into the joint.
How did that get into the world?
That got into the world, I believe, through Jason Dragoo, who created a slide that he compared and said, well, the studies that are available right now, which did not report dose, basically he noted that the ones that were failing were leukocyte-rich, and the ones that were succeeding were leukocyte-poor. And I think that's how it got into the world. Correct me if I'm wrong.
Yeah, I want to make one more additional, not so popular comment right now as well, if I may.
Sure.
A lot of physicians were afraid that the inflammation from the white blood cells would keep them awake overnight.
Sure.
Patients start to call, hey, listen, my knee is getting stiff.
Really hurts. Yeah.
No, stiff. Stiff is not pain, right?
Okay,
I mean,
sure.
I had it done myself
Yeah.
a couple times,
Yep.
and it's stiff. It doesn't feel comfortable, but doesn't hurt,
Yeah.
right? So for some reason, well, what you mentioned, because now the nice thing is, when you look at the literature, there's no difference between the leukocyte poor and the leukocyte rich from an outcome perspective.
That's correct.
Apart from the fact that patients who get leukocyte rich report far less pain.
So far less pain, you're
yes,
saying?
the pain killing effect after the phase of the acute inflammatory response, the pain killing effects with the leukocyte rich is more pronounced than the leukocyte poor.
They get there quicker.
Yeah.
Got it.
And more durable.
Sure.
So what we've seen in a huge study only in knee pathologies is pain killing and functional repair was significantly better in patients who received leukocyte-rich PRP intraarticular.
Okay. Anecdotally, I don't know if it was the bigger dose of platelets or the white blood cells. Obviously I was going from a low dose system with essentially no white blood cells. They would get flares, but I did feel that there was a bump in the pain, anecdotally, obviously, from doing higher doses. In terms of because leukocyte-rich is a little bit of a broad term, right?
Yep.
If we separate them a little bit, I can understand and buy into, a monocyte-rich preparation, the platelets stimulated from M1 to M2, now you're gonna get an anti-inflammatory monocyte. So I can buy into that, a monocyte-rich intra-articular injection. Where I have a little trouble is sometimes with neutrophils. I understand the concept of, they all work together, right, in the environment, but for me, when we look at histological data on cartilage and osteoarthritis, neutrophils are actually a bad marker, right? Or angiogenesis would be a marker of degeneration. So I guess, what is your concept of what the neutrophils are doing, and hence why, and correct me if I'm wrong, you are a proponent of including them in a joint injection, or what are your thoughts on it?
Technology right now doesn't allow us to only get platelets and monocytes.
Agreed.
I mean, due to the density differences, they're very closely to each other.
Yeah.
So there need to be different kind of technologies. Eventually, to only have a leukocyte monocyte-rich PRP.
Yeah.
It's not yet there, if ever it's going to come. But keep in mind, neutrophils have also a polarizing capacity.
Okay.
So we have neutrophils type 1 and neutrophils type 2.
Okay.
Not many people know that. But
I did not know that, yeah.
The same with monocytes. You have different phenotypes from leukocytes as well. So again, what is the goal of your therapy? You always have to ask that.
Great call, yep.
If you want to induce angiogenesis, not neoangiogenesis, but angiogenesis, you need to have the neutrophils.
Got it.
So the synergy between particular growth factors from platelets and neutrophils, they support the angiogenetic pathway of healing, which is, by the way, a cascade of healing we never discuss as well.
You're right.
We only talk about the classical healing cascade, right? We never talk about the angiogenesis cascade of healing.
Sure.
But when you dive into the angiogenesis cascade of healing, which contributes to a lot of restoration and functional repair, then you will appreciate the presence of neutrophils there. And they only create temporary inflammation. Not because
they don't have a negative long-term
effect.
No.
We need to understand the difference between acute inflammation and chronic inflammation.
Understandable.
And the traditional healing cascade, which we all know, well, hopefully well, it has neutrophils in there, right?
Yes.
It has that inflammatory phase in there. So who are you and I to decide we take that off and forget about the healing cascade, and we'll pick up at a better pace, at a better organization than what it is.
Well, and to be fair, I will also say, my understanding is that there's more neutrophils than monocytes, correct? In general terms, in whole blood, let's call it.
You will be surprised if you do an analysis from whole blood and PRP, what the increase in monocyte is. That's way more than neutrophil. Because you take a partially layer of the buffy coat. You don't take the full buffy coat deep into the red. Yeah. So the increase in monocytes could even be more important, could be, let me be very careful, could be than the effect of the platelets.
Got it. Well, I guess the point I was trying to make is that even myself, when I make a high dose PRP injection, I am able to increase the monocytes. I can reduce the neutrophils, but they're not eliminated. And I think to your point, so even though I'm injecting this monocyte-rich PRP, it still has neutrophils, and the effect has not been necessarily negative.
No, because what's changing is, compared to whole blood, is the ratio of the cells.
Okay.
So when you look at, for example, the ratio of the red cells and platelets in whole blood, or the ratio between PRP and RBCs and platelets, that's completely different one. So the effects of a hemoarthritic joint, right, that's a whole blood product. When you inject a leukocyte-rich, it has some red cells. The ratio between any of the white blood cells and the platelets is completely different. So therefore, the effects from cartilage damage with blood in the joint and PRP that has maybe a hematocrit of 10-12%, that doesn't even get close to what we would have as a whole blood trauma injury.
Okay. Now, I will say today, Peter dropped a bomb at the Biologics Association during his lecture, which was subtle, and I think some of us picked up on it. I don't know if you're ready to talk about it.
Yeah, of course.
But MPV, right? And this concept of trying to go after platelets that are in a state that will have more growth factors. Can you explain to us a little bit the concept between of MPV? Because I'm also trying to understand it myself. So
there are a lot of platelet indices, right? Like platelet count, mean platelet volume, platelet crit, platelet distribution width. They're all being given to you when you have modern analyzer for free.
Got it.
So you do your CBC, and based on the sample, you will have those data available. What I tell the story is the following. You have osteoarthritis. You have sensory nerves from your joint going to your brain.
Correct.
Your brain needs to process the information that's given from your osteoarthritic knee. So the brain is directing the sympathetic nerve system, hey, listen, his knee is hurting, we need to fix that. That's what we call a hemostatic tissue response. That means that the sympathetic nerve system signals your bone marrow. We are not going to go into that. But what happens is that the bone marrow is going to respond to that signaling pathway.
Got it.
So they make the hematopoietic stem cells produce more megakaryocytes, and they instantly start to release these big, huge platelets. They're going to go into the bloodstream. Platelets have a life expectancy of 7 to 8 days. They're done. Patients who have a low MPV, they have on average all the platelets to work with.
Got it.
Any injury, any bleeding or whatever releases fresh platelets from the bone marrow. So what's the big difference between old and young platelets? That's first of all their size.
Got it.
Their density. And the density is directly correlated to what's inside the platelets.
Got it.
So if you have denser, bigger platelets, they have more granular content. There's been a nice study published looking at how the density of platelets affects the number of VEGF growth factors. Highly significant. The denser the platelets, the more VEGF you have. Right. So the matter is, do we need a higher concentration with a lower size, smaller size platelets? Or maybe, because that's also a proven relationship, that if platelets are more dense, the number of platelets will go down. Because they are bigger.
Got it.
Right? So at some stage, what we just briefly touched on today is maybe what we're doing is we're hiding behind our blood cell analyzers in the lab. So now look, hey, I have 10 times the baseline, I have 10 billion platelets here. Maybe that's not enough, let me be polite. Not enough. So what could happen is that if you understand the mechanism better of you only have bigger, fresher platelets, the concentration, the number of platelets that we need is going to go down. Exactly.
Okay.
And when we look at our bone marrow data, we already see, well, if you go deeper in the bone marrow cavity, you will have these big fresh platelets waiting there to be released into the peripheral bloodstream.
Wow.
And we measure that. Have you seen on the slide?
Yes.
So there is something going on, because we always thought that the density of platelet was a fixed number.
Yeah.
When you go back into the literature, into the 1970s, by a nice Dutch group, by the way.
Yeah.
Seriously, from a Dutch group.
Sure.
That range could vary from very high in the plasma to deep in the red blood cell layer. So platelets are all over the spectrum.
Got it.
And if we only capture this piece here and the buffy coat is here, the bigger ones here we don't reach. So based on your initial sample, hey, listen, this patient has a high mean platelet volume, MPV. Maybe we should get some of that layer below as well to capture these platelets.
Get the bigger, more powerful platelets.
Absolutely.
Got it.
Absolutely. And that's what we're doing together with Luga now in a trial to understand it better. And it's too early to say, but we have a feel when we look at it that these patients have a different response rate than when we take only superficial platelets.
Got it.
And the number therefore would mean, okay, buffy coat layer here, plasma layer here, platelets in between. When we need to capture these platelets, that dose might even be 20 billion that you need to make a clinical significant difference. If you take these and the ones over here, that's going to be a completely different story. So that's something we
packed with many more growth factors.
That's what we need to work on in the future.
Well, there you have it. That's that is deep info that you're only getting here.
Yeah.
So I got to admit, this is the first I've been hearing about it. So I'm glad we're able to chat. So I don't want to take too much of your time.
No, go ahead.
We're really appreciative here. Well, let's see. There's a couple things. Is there any patient subgroup that may not need such a high dose? So again, if we don't talk about MPV, we're talking about the original thought of 10 billion. That's the first question. And then second, you mentioned that you've had some conversations with Bansal, and just a plug for your conference coming up in Belgium. I know he's going to be speaking there. You guys are now seeing that 10 billion a little bit differently. So I guess first question is there a subgroup that may not need such a high dose? And B, what's your new concept around 10 billion?
Yeah, perfect. Yeah, good questions. So the 10 billion only is indicated at this stage, or preferred injection dose for knee OA, for osteoarthritic conditions.
Got it.
For soft tissue, it's a different story.
Okay.
We could go far less. When we did our analysis from the literature, any dose between 3 to 4 billion will give you a positive outcome.
Got it.
So all of a sudden that number goes down tremendously.
Sure.
But that's only when we look at the literature related to the fact I have other cells with it.
Okay.
Because with tendons and ligaments, we mostly use leukocyte-rich plasma, right?
Yep.
So we have other cells and molecules that having a different effect on the repair. So that number is different. Bone, for example, if you want to do bone stimulation with fractures or non-union pseudoarthrosis, you definitely don't want to go at least 4x the baseline, because you will have more osteoclastic effects.
Gotcha.
And
so you want a lower dose?
You want a lower dose.
Got it. And what about white blood cell count? Do you go leukocyte poor? Does that matter?
If you don't have neutrophils,
yeah.
If you don't have neutrophils with your PRP in bone, you won't have any osteoblastic activity.
Got it. There's no healing that happens.
No, you need to have neutrophils in there. So to your other question with Dr. Bansal is, well, 10 billion was the number of platelets.
Yeah.
Right? But what is the driving factor within the platelets that create a positive outcome?
Mm-hmm.
What is it?
Within the platelets, the growth factor content? The number of alpha granules?
That's related, right?
Yeah.
It could be the case we're talking about different molecules, acellular molecules, like exosomes.
Oh, gotcha.
Yeah, so we have not yet figured out, and I have to apologize for all the scientific work we have been doing. we missed looking at some very powerful contributors to resolve the complaints of knee OA.
Got it.
And that might be something else that's not defined as PRP platelets, but something that's in the platelets that we never discussed. That may be platelet-derived exosomes.
Okay.
So that's a discussion that we're going to bring forward at the conference as well. So yeah, we're not yet done.
Yeah, no, we're just getting started. All right, we'll do 2 quick fire rounds. So one, what's your favorite memory from working in the Netherlands?
My favorite memory?
As you got your PhD over there?
Yeah, I got my PhD over there. That opened up a lot of doors. And I have always been a fan of biological tissue repair.
Yeah.
So I was very lucky to find partners to set up a biological wound care clinic. So we combined hyperbaric medicine with PRP, with bone marrow concentrate, adipose tissue. And we had one of the highest wound closure rates in the world, based off the concept of biological healing. Wow. Where insurance companies knocked on the door, how much do you charge to treat my patients? Sure. And they paid for it because they figured out the concept of care ultimately has a high price, but the end result was a final result instead of amputations or prosthetic joints or vascular surgery. So that still to me is a memory, you won't be able to erase, Alberto.
All right, and last one PRP myth that you wish would disappear forever.
Myth?
A myth.
My myth or my experience or
your experience or in general, just something that, hey, I wish people would stop saying this about PRP.
Also this conference. Okay, let's be honest. We talk about PRP.
Sure.
Like every PRP is the same.
Right.
We look at meta-analysis, systematic reviews. PRP makes no difference. Of course it doesn't make any difference because we never were able to standardize what PRP is.
Gotcha.
We never were able to come up with decent preparation protocols. We were never able to distinguish, okay, this tissue needs this kind of PRP and whatever. So generalizing PRP therapies as I make PRP one size fits all, no bueno, said somebody else. And we have to say it again, no bueno.
No bueno.
We have to really understand, PRP is patient specific.
Yeah.
The other variables are you as a physician,
Sure.
what kind of PRP you're going to inject and how you're going to inject, right? And we need to make this a pathoanatomic specific product.
Yeah.
And we cannot say, this is PRP and it's going to work for your face, for your hair, for your knee, for your tendons. That's simply no bueno.
No bueno. Well, Peter, thank you so much.
Thank you, my friend.
I really appreciated the time.
Thank you.
Hope you guys enjoyed that.
Thank you.
Any questions, always feel free to reach out to any of us, and always go back and read all the papers that we talked about, and it'll even help you more to really grab these concepts. Have a good one.
Thank you. Good night. Bye-bye.